Level 1. The Anatomy Lab Gambler. You are 22, standing over a stainless steel table with a $10 box cutter in your backpack, $200,000 of possible debt in your future, and a dead body in front of you that just turned your fantasy into a smell. This is your first real surgical moment, and technically it is not surgery at all. It is anatomy lab. Gloves on, scalpel in hand, formaldehyde in the air. You thought becoming a surgeon meant action, genius, and some dramatic television version of confidence. What it actually starts with is memorizing nerves that look like wet strings and realizing how easy it would be to get lost inside a human body. You are not paid. You are paying. Hard. Tuition, fees, exam prep, rent, coffee, parking, and the weird extra costs nobody mentions, like scrubs, anatomy atlases, and practice question banks. If you are in the United States, average medical school debt often lands around $200,000 to $250,000. You tell yourself it will be worth it because surgeons make surgeon money. That sentence will carry you through years of sleep deprivation and extremely bad cafeteria eggs. In your first 2 years of medical school, you believe the smartest person wins. The one with the best scores, the fastest recall, the cleanest notes. Then you hit your surgery rotation in third year and learn the harder truth. Surgery is physical, hierarchical, public. You are no longer just trying to know the answer. You are trying to know the answer while being stared at under bright lights by a person who has not slept enough and still somehow remembers the blood supply to everything. The first time you scrub into an operating room, you feel like an intruder at a ritual. The sink timer buzzes, the water runs down your elbows, the gown goes on without touching the wrong surface, somebody ties you in. The room is cold, precise, and weirdly quiet, except for monitor beeps and metal instruments touching metal trays. Your job is useless and critical at the same time. Do not contaminate anything. Do not faint. Hold the retractor. If you are lucky, maybe cut a suture. You think surgeons are gods. Then you meet actual surgeons. Some are brilliant and generous. Some teach by asking questions like they are loading a weapon. Some are funny in the driest possible way. One tells you, if you want a normal life, leave now. You laugh because you think he is joking. Then comes the first ego check. You freeze on a simple anatomy question in the middle of a case. You know you studied it. You know you saw it last night. Gone. Vapor. The chief resident answers in half a second without looking up. You feel 10 years old. That humiliation matters. Surgery attracts people who hate looking weak, and the latter begins by making you look weak in public over and over until you either toughen up or walk away. At this level, the real tool is not the scalpel. It is the ability to keep showing up after embarrassment. You chase strong grades, research, letters of recommendation, and a good score on your licensing exams, because surgery residency spots are competitive and the path is narrow. General surgery alone can take 5 years after medical school, and many people add more training after that. You start doing the math and realize this career can consume at least 11 to 15 years after high school before it feels remotely stable. Then match season arrives. One envelope or one screen tells you where your 20s are going. You are not asking, can I be a surgeon anymore? You are asking, who is going to let me suffer enough to become one? Level 2, the intern with the pager. You are 26 or 27, new doctor, short white coat swapped for longer one, real badge, real patience, real signatures, real terror. At 4:17 in the morning, your pager goes off because a post-operative patient has a fever and low blood pressure. You run down a fluorescent hallway with one shoe half untied, trying to sound calm before you feel calm. This is the first year after medical school, the intern year, and it is where the romantic image of surgery gets beaten to death by logistics. You thought surgery would be about operating. Most of intern year is not. It is notes, orders, drains, wound checks, phone calls, blood draws when nobody else can get the line, and trying not to miss the one detail that kills somebody. You are the bottom brick in a tower of responsibility. You get blamed for things above your pay grade and thanked for almost nothing, which is useful training for life. Your salary is finally real, but only in the technical sense. Depending on hospital and city, many first-year residents make something like $55,000 to low 60s a year. In Manhattan or San Francisco, that can feel like a prank. You are working 80-hour weeks on paper, and sometimes it feels like more in spirit. You divide the paycheck by the actual time and stop doing that calculation, because it is too depressing. Your tools are not glamorous. Trauma shears, stethoscope, pens you steal back, a list folded into your pocket, a pager that sounds like bad news even when it is not. You are learning to place basic lines, close skin, write post-operative orders correctly, and present a patient in 30 seconds without sounding lost. You also learn that the operating room is only the visible tip of surgery. The real job includes everything before the incision and everything after it. The hard lesson here is that fatigue is not noble. Fatigue is dangerous. You forget things when you are tired. You get sharp with nurses when you are overwhelmed. You miss dinner. You miss birthdays. You call your family from a stairwell and try to sound like a functioning adult while eating crackers from your pocket. This is where some people leave. General surgery residency attrition is often reported around the low to high teens, roughly 13 to 19% depending on the program and study. Not everybody who starts finishes. Then comes your first small win. You close part of a case. It is not elegant, but it holds. Or you get through a night of pages without spiraling. Or a senior resident says, "Good catch," and that single sentence buys you another 3 months of effort. You begin to understand that becoming useful is addictive. You are still clumsy, still slow, still wrong a lot, but now there are moments when your presence actually lowers chaos instead of adding to it. That is enough to keep going. And because this is surgery, the reward for surviving intern year is not rest. It is more responsibility. Level 3. The junior resident under the lights. You are now a second or third year resident. The operating room door opens, and for the first time, you are not just extra hands. You are expected to do pieces of the operation. The attending surgeon stands across from you. The chief resident watches like a hawk. The patient is asleep, prepped, draped, and trusting a system they will barely remember. Your gloved hand holds the scalpel. Incision, someone says. Suddenly a movement you practiced on foam pads and pig feet and simulation models has real stakes. This level is where your identity changes. You start to believe quietly that you may actually become a surgeon. Then surgery punishes overconfidence immediately. Your first skin incision is too timid or too wide. You fumble the needle driver. Your knot looks ugly. Laparoscopic surgery turns your hands into a joke because the instrument tips move in strange directions and depth perception feels borrowed. You can be academically excellent and still look like you have never used your arms before. Your pay rises a bit, maybe into the 60s or low 70s depending on region and year. Still not great. Still better than zero. Your debt may still be accruing interest unless you arranged a specific repayment plan. Friends outside medicine are buying houses, getting promotions, taking vacations with actual itineraries. You are learning how to stay awake through a 6-hour case after being called all night. Now you start collecting cases, appendectomies, hernias, gallbladders, trauma explorations, maybe some breast, colorectal, vascular, or endocrine exposure depending on the program. During residency, people often talk in case numbers because numbers become proof. You need enough repetition to stop narrating every move in your own head. Across training, residents may log hundreds of operations, and in many stretches, a resident might be directly involved in roughly 150 to 200 cases a year, depending on the specialty mix and role. The exact number matters less than the shift it creates. The body stops being a mystery and becomes a map with consequences. You also learn operating room politics. Anesthesiologists want the patient stable. Nurses want the count correct and the room safe. Surgical technologists know when your movements are sloppy before you do. Nobody cares that you are still learning if your mistake creates bleeding. Teamwork stops being a buzzword and becomes survival. This is also the level where your first real mistake can haunt you. Maybe you tear tissue because you use too much force. Maybe you miss a post-operative complication on rounds and a senior catches it. Maybe you contaminate your gloves and do not notice until someone else points it out in front of the room. No music plays when these moments happen. Just heat in your face and a note burned into memory forever. But there is another side. You start hearing your own voice become calm during bad moments. Suction. More light. I need another tie. You learn the beautiful, boring discipline behind safe surgery, timeouts, antibiotic timing, correct site verification, counting instruments, checking imaging, anticipating blood loss, respecting anatomy. Surgery is dramatic from the outside. From the inside, great surgery looks repetitive on purpose. At this level, you pick your future obsession. General surgery can be the destination, but for many people, it becomes the highway to somewhere narrower and harder. Trauma. Surgical oncology. Pediatric surgery, cardiothoracic surgery, vascular surgery, plastic surgery, colon and rectal surgery, minimally invasive surgery, transplant. The more you see, the more a certain room starts pulling you, and once one kind of case gets into your head, fellowship starts whispering. Level 4, the chief resident, everyone watches. Now you are a senior resident, maybe in your final year. Same hospital hallways, different gravity. At 2 in the morning, the emergency department calls about a perforated bowel, a crashing trauma, or a strangulated hernia. The junior resident looks at you before anyone else. The intern is waiting for orders. The attending surgeon is on the way, but until they arrive, you are the person in motion. This is the level where you stop borrowing authority and start wearing it, at least temporarily. You run rounds faster. You know which consultant to call and which one to avoid until you have more data. You can smell when a patient looks wrong before the lab values finish proving it. That instinct is expensive. It costs sleep, shame, repetition, and hundreds of tiny corrections. Your salary inches upward again, often into the 70s, maybe low 80s in some systems. The money still does not match the responsibility. You are now trusted with more operative autonomy, more teaching, and more triage. A medical student watches your hands the way you once watched the chief. You hear yourself repeating lines your seniors said to you, and some of them sound smarter now. Chief year is weird because you are both almost there and absolutely not there. You may lead pieces of complex cases, make first-pass plans, and supervise junior residents, but the attending surgeon is still the legal final answer. The attending can rescue your bad decision in seconds. You are learning how much courage it takes to decide, and how much humility it takes to reverse yourself. This is also where the career starts splitting. Some of your co-residents are done. They will become general surgeons and step into community hospitals, employed groups, military practice, or rural areas where broad competence matters more than hyper-specialization. Others are assembling fellowship applications, research papers, recommendation letters, and one more round of proving they belong. A fellowship usually adds 1 to 3 more years, sometimes more depending on the path. In exchange, you get narrower expertise and often a better shot at certain jobs and higher pay. The hidden lesson of chief year is that surgery is not just hands, it is judgment under uncertainty. You can do a beautiful anastomosis and still lose if you should never have operated in the first place. You can cut perfectly and communicate badly and still create disaster. Families remember whether you showed up after the complication. Nurses remember whether you listened. Trainees remember whether you taught or humiliated. Burnout becomes impossible to ignore here. Studies often put surgeon burnout high, with roughly half reporting it at some point. You see why? Your body is durable until it suddenly is not. Your relationships survive on deferred promises. You are impressive on paper and strangely absent from your own life. Some people double down. Some quietly wonder whether the title is eating the person. Then the final residency case ends. You take the photo. Maybe you smile. Maybe you just feel hollow and relieved. Either way, another door opens. You can finally practice independently soon. Unless, of course, you choose to become a beginner again in a smaller, meaner kingdom. Level 5. The fellow who starts over. You picked a specialty because one kind of problem kept pulling you back. Maybe it was the elegance of vascular surgery, the marathon brutality of cardiothoracic surgery, the precision of pediatric surgery, the life and death chaos of trauma and critical care, the meticulous margins of surgical oncology, or the robotic finesse of urology or minimally invasive work. Whatever it was, fellowship is where you admit general competence is not enough for your obsession. Your first day as a fellow feels familiar and insulting. New badge, new attendings, new scrub staff, new unwritten rules. You were a chief resident yesterday. Today you are once again the person who does not know where they keep the special stapler. That is the emotional price of specialization. You surrender status to gain mastery. Depending on specialty and setting, fellowship pay may still look like trainee money or maybe somewhat higher, often roughly in the range of resident pay and occasionally more in certain systems, but not attending money. Some broad estimates put fellows anywhere from about 70,000 into low hundreds, though numbers vary a lot by place and structure. The point is simple. You are still underpaid relative to the value you are producing, and your debt still knows your name. The tools become more exotic. Endovascular wires, microscopes, robotic consoles, bronchoscopes, aortic clamps, delicate pediatric instruments so small they make standard tools look crude. Technology can be amazing, but it does not save you from bad judgment. A robot is not magic. It is a very expensive extension of your own skill, and the first time you sit at a robotic console, you learn that advanced still means awkward at first. This level teaches you the difference between being good and being trusted for the hardest version of good. Community gallbladders are one thing. Redo chest cases, tiny vessels, tumors wrapped around critical structures, unstable trauma, or neonates measured in pounds instead of kilograms are another planet. You also begin board preparation in a more serious way. In the United States, that means the licensing examination steps are behind you, but specialty board certification still matters. Passing written boards, then often oral boards later, is not just a formal badge. Hospitals, groups, and patients read it as proof that an independent body thinks you are safe enough to carry the title. The fellow year, or years, are often where your mentor changes. Residency taught you how to survive. Fellowship teaches you what your hands can become. Maybe a senior surgeon shows you one move with a needle that cuts 20 minutes off a case. Maybe they show you how to stand. Maybe they show you when not to chase perfection because speed now serves safety. The best mentors do not just make you more skillful. They make you less dangerous. Then the final insult arrives in the nicest packaging: job offers. Suddenly, hospitals, private groups, or academic departments want to know not how teachable you are, but what you are worth. After a decade of asking permission, you now have to choose where your adult life happens. Level 6. The attending with no safety net. This is the jump outsiders think is the finish line. You are an attending surgeon now. The case starts, the room turns toward you, and there is no higher clinical authority inside that room to hide behind. If something goes wrong, the rescue plan is also you. The first time you sign the consent, mark the site, and walk in knowing the final call is yours, it lands in your chest differently. Residency and fellowship gave you skill. This level gives you liability. The money finally changes shape. Depending on specialty, region, call burden, and practice type, attending surgeons can earn roughly $300,000 to $800,000 a year, and some highly paid subspecialists can go above that. The average surgeon figure people quote may be around the low 300s, but averages hide a lot. Trauma in a major city is not private spine in a wealthy market. Academic salaries are often lower than private practice. Rural jobs may pay more because the need is greater. Some offers include signing bonuses, relocation help, loan repayment, or productivity incentives. None of that matters at 3 in the morning when an anastomosis is leaking and you have to decide whether to take the patient back. At this level, your calendar becomes an operating system: clinic days, operating days, emergency call, committee meetings, morbidity and mortality conference, board exams if not completed, continuing education forever. Surgeons do not really arrive and relax. Medicine changes, techniques change, devices change, evidence changes. If you stop learning, you become dangerous in slow motion. The emotional shock of early attending life is that freedom and loneliness arrive together. You can finally choose how you operate, how you counsel, how you run your room, how you build your reputation. You can also no longer blame a bad plan on training. A complication can keep you awake for weeks. A good result can carry you for one afternoon. This is where your reputation starts writing checks your future will have to cash. Are you the calm one, the fast one, the technically gifted one, the one who takes impossible cases, the one who is impossible to work with? In surgery, word travels. Referrals travel, so do whispers. Patients also change at this level. As a trainee, they were often the case. As an attending, they start becoming your people. You see them before, during, and after. You tell a family the operation went well. You tell another family it did not. You learn that the cut is only one part of surgery. The conversation before and after can matter just as much. A surprising number of new attendings discover the money does not instantly erase the damage. There is delayed adulthood to catch up on, debt to attack, maybe a house, maybe a partner who is tired of being patient, maybe children who know your voice better on speakerphone. Surgeons can look rich from the parking lot while still feeling personally behind. But if you stay long enough, competence hardens into style. You stop simply doing surgery. You start building a practice. Level 7. The name people ask for. A few years pass, maybe 5, maybe 10. You are no longer the new attending. Your schedule fills because someone requested you specifically. This is the level of pattern recognition and consequence. You walk into clinic and know in the first 60 seconds whether a patient needs an operation, another scan, another specialist, or a hard conversation about why surgery would be the wrong answer. That last one is underrated. Mature surgeons are often defined as much by the operations they refuse as by the ones they perform. Financially, this can be the most deceptively strong period. Productivity bonuses kick in. Referral networks stabilize. If you are in private practice or a high-volume employed model, yearly compensation can move toward the upper ranges for your field. In some subspecialties, especially procedure-heavy and market-favored ones, numbers can get very high. But the overhead behind those numbers is real if you're in a private group. Staff, malpractice insurance, rent, billing, technology, electronic record systems, call coverage, and equipment that can cost far more than a luxury car. A robotic platform alone can run into the millions when you factor in purchase and ongoing costs. The glamorous salary headline never mentions the invoices. Your tools now include junior surgeons. You teach residents or fellows if you are in an academic center. You train physician assistants or advanced practice clinicians in your workflows. You build teams that make your outcomes possible. You also inherit politics, block time fights, department budgets, recruitment, quality metrics, peer review. The higher level of surgery is partly leadership and partly bureaucracy with sharper consequences. The hard lesson here is that mastery does not reduce emotional exposure. In some ways, it increases it. You have more patience, more complexity, more expectations, and less excuse. A complication in year 1 feels like panic. A complication in year 10 can feel like betrayal. You know enough to imagine every branch where things could have gone differently. This is also when some surgeons split into different endgames. One path is pure operator, the technical star whose cases everyone comes to watch. Another is the builder, growing a private practice or a multi-specialty group. Another is the academic name, publishing, trial running, lecturing, training the next generation. Another becomes the fixer, the person in hospitals call when a service line is failing or a difficult case needs a calm hand. And your younger self would find this funny. At the level where you seem most powerful, what matters most is often the least cinematic thing imaginable. Consistency, showing up, returning calls, owning mistakes, not acting like a genius because you had a good month. If you keep climbing, the operating room stops being the only room that defines you. Now you are being pulled toward budgets, hiring, strategy, and the power to shape how surgery happens around you. Level 8. The chief, the partner, or the builder. This is where surgeon stops meaning only operator and starts meaning institution. Maybe you become chief of service, division chief, department chair, or medical director. Maybe you become a full partner in a private surgical group. Maybe you build a niche center around bariatrics, orthopedics, vascular access, colorectal care, cosmetic surgery, fertility-related procedures, or another procedural lane where systems matter as much as hands. The titles differ. The shift is the same. Your mistakes can now affect entire teams, not just one patient. If you enter leadership at a hospital or academic center, compensation can rise above senior attending levels, sometimes roughly 20 to 30% more, though structures vary wildly. If you are in partnership or ownership, the number can be far higher or far messier. A successful private practice surgeon owner might net several $100,000 and in some markets over $1 million a year, but only after overhead, taxes, staffing, and constant business pressure. It is not free surgeon money, it is surgeon money with payroll attached. Your opening scene at this level is not always an operation. It may be a spreadsheet, a contract negotiation, a call about malpractice premiums, a meeting over operating room turnover times, a complaint from a family, a review of a bad outcome, a decision about whether to spend a small fortune on new imaging, a robotic system, or expanded clinic space. This level exposes the myth that elite surgery is pure craft. It is craft plus systems. You can be the best pair of hands in the building and still lose if your service line cannot recruit, retain staff, negotiate payer contracts, document correctly, or protect quality. Leadership surgery is less blood, more leverage. The emotional test here is identity. If your whole self was built around being the person who operates, leadership can feel like betrayal. More meetings, less cutting, more politics, less immediate feedback, but this is also where legacy begins. You can change call structures so trainees do not break the way you did. You can open access for underserved patients. You can build safer pathways, better teaching, stronger culture. Or you can become one more burned out tyrant everybody avoids. Some surgeons at this level also branch into device consulting, medical legal review, startup advising, board roles, public speaking, or specialized outpatient centers. Not every surgeon owns a giant practice. Not every surgeon should. But this is the first level where your name can generate income and influence beyond the next case. And eventually, one question starts sneaking in between all the status. How long do you want to keep doing this with your hands? Level 9. The legacy hand. You are now late career, maybe in your 50s, 60s, or beyond. The residents whisper that you trained before robotic surgery became common. Then they watch you tie a knot and go quiet. This level is not about raw speed anymore. It is about economy. You move less and accomplish more. You do not waste force. You do not waste words either. You have seen enough complications to know confidence should sound gentle. Your income may still be excellent, especially if you have equity, partnership distributions, leadership pay, consulting income, or a highly established referral base. Or maybe you intentionally cut back and earn less because time has become the scarce thing now. Endgame money for surgeons varies wildly. Some finish as comfortably paid employees with pensions or retirement accounts. Some sell stakes in surgery centers or practices. Some slowly taper clinic and call while mentoring younger partners into ownership. There is no single billionaire-style finish line here. The real flex is control. Your opening scene might be handing over the lead on a major case to a younger surgeon while you supervise, or walking a fellow through a dangerous dissection one sentence at a time, or sitting with a family longer than your schedule allows because you finally know the extra 7 minutes matter more than pretending to be efficient. At this level, people ask for your judgment when the case is ugly, when the imaging is ambiguous, when the prior operation failed, when the room feels uneasy. Your technical skill still matters, but your greatest value may be that your panic threshold is far away. This is also where the cost comes into focus. You remember the anatomy lab, the pager, the call nights, the missed anniversaries, the debt, the funerals you could not attend, the people you helped, the people you could not save. Surgery gave you authority, income, and a place in rooms where life changes fast. It also took pieces in installments. Some surgeons leave the operating room abruptly after injury, burnout, eyesight changes, or the simple honesty that they no longer want to be the final pair of hands. Others taper with grace. The best ones know when skill is peaking and when identity is just clinging. Then one day you hold a scalpel for teaching, not for doing, and the whole ladder closes. Final beat. The blade and the bill. You started with a cheap blade in a backpack and a fantasy about status. You end with a practiced hand, a reputation, maybe a 7-figure year at the peak, maybe leadership, maybe ownership, maybe a generation of surgeons who still repeat your habits without knowing where they got them. From the outside, the ladder looks like money and prestige. From the inside, it is embarrassment, debt, hierarchy, repetition, missed sleep, public corrections, private doubt, and the slow miracle of becoming useful with a knife in your hand. The final truth of a surgeon is simple. You do not climb this ladder because you love being called a surgeon. You survive it because, after enough years, enough pages, enough blood, and enough fear, you learn how to walk into the brightest room in the building when everybody else wants out.